also important for you. But do not do this test. Why? Because this is a test to evaluate atlanto-occipital or atlanto-axial instability. And if you truly think your patients had such a trauma as they have an unstable atlanto-axial joint, by that I mean dislocated, you do not want to provoke it, which is exactly what the Sharp Purser test does. So I'll show you how to do it, just like when we get in another section, I'll show you how to do Hohenstein, but that's old news. You don't do Hohenstein. There are other tests like the bracelet test that comes up once in a while. I don't even teach it. It's so useless. I just refuse. But for RA, it's just a useless test. But bottom line, Sharp Purser test. So here's the thing. Can I have someone I can demonstrate this on, please? That doesn't have neck pain. Thank you, sir. Face your podness and crime. Sit on the chair for me. Yes, sir. So here's the thing. If the patient has, what could cause the atlanto-occipital joint to become unstable? I mean, I'm not talking about mechanism of injury. I'm talking about anatomical failure. What could happen?
Dense
The
fracture.
alar ligament, but no. But that's a reasonable guess. What holds the atlas to the axis?
The apical ligament.
The transverse ligament.
Transverse.
And it is a robust ligament. And you'll see I have a photo where I demonstrate Steele's rule of thirds. There's a beautiful dissection, live anatomical, not live, but it's a photo, not a diagram, of an anatomical section done by Dr. Rauschning, who's the best anatomist I've ever, he does such good work. And it's essentially as if I took a buzzsaw and cut right through the center of my atlas horizontally, pulled my head off, tilted my head over, and you looked in. If in that photo for Steele's rule of thirds, you'll see that the transverse ligament is not a little dainty ligament. It is a robust ligament, basically because it holds your head to the rest of your body. Not solely, but it has a significant part. So what can cause a deficiency or insufficiency other than trauma of the transverse ligament? Any ideas, any conditions you can think of? There's one called trisomy 21, which is also known as Down syndrome, not Down syndrome, it's Down syndrome. That's one thing. Another big one is rheumatoid arthritis, because rheumatoid arthritis is a disease of the synovium. Oh crud, I should be taping this. Oh god.
I got it. I got it.
I gotta post it on Blackboard.
Oh.
So we're talking about the Sharp Purser test, we're talking about atlanto-axial instability, and we're going to talk about how the transverse ligament can be compromised. One way is trisomy 21 Down syndrome. Another way, much more likely for you to see, is rheumatoid arthritis, because it's a disease of the synovium, synovial joints, and that's a synovial joint. So it erodes that ligament slowly. Doesn't mean it's going to rupture it, but it can weaken it. It's like a rope composed of many fibers. If you cut it halfway, it's still going to be together, but it's going to tear more easily, and it's not going to be as strong, right? So that's the transverse ligament. So if the transverse ligament is deficient, insufficient, or worse, ruptured, and I'm going to show you a photo of a guy with, bless his heart, that has a ruptured transverse ligament, a real-life guy. What will happen is the head weighing about 10 or 12 pounds in an adult human, gravity, if they lean the head forward, it'll tend to slide forward.
Ooh.
And so, yeah, it's right. So, have you guys gotten in radiology yet to atlanto-dental interval, ADI? Okay, well then I won't get into that now, but there's a certain space that should be present between the anterior aspect of the dens and the posterior aspect of the anterior arch of atlas. Should be less than 3 millimeters in adults and less than 5 in children. But the test itself, so let's say our good friend has atlantoaxial instability. And I, kind of stupidly, say, let me see if I can provoke it. I'll do the Sharp-Purser test. So the way the Sharp-Purser test is done is according to the classic way to do it, but at my station there was an acceptable variant. From I think it's McGee, they show you doing it with the tip of the thumb. And the way that works is, you're gonna, the idea is this. This is the why, and this is the basic stuff. You're gonna take your according to that McGee, you're gonna take your thumb and you're gonna push forward on the axis spinous. You're gonna push backward on the forehead in a shear motion. So what happens is the patient's going to lean their head forward, and as they do so, you're gonna push back with the head and forward on the spinous, and you will feel, or worse yet, hear a clunk as it relocates.
It's creepy.
So we really don't want to do that. If I suspect true atlantoaxial instability, I am not going to be provoking it. The way I want you to do it is to use this joint of your knuckle, because it's more comfortable for the patient. Plus the thumb is a little harder to get right on that spinous. It's easier to be off it. If this is the spinous, it's easier. If you do it this way, you might get lucky. If you do it this way, you're going to get much more lucky. So I'm going to show you what I'm talking about. So my patient with his suspected atlantoaxial instability, may I place my hand on your forehead? Sure. I'm going to place my hand on his forehead. I'm going to take my knuckle and put it on the axis of C2. I'm going to have him tilt his head slowly forward, and as he does so, I'm not going to really do it as you're supposed to, because it's uncomfortable even on a normal neck. So when you're doing it with each other, don't be too enthusiastic, okay? So I'm going to, as his head's going forward, I'm going to push back. This is the direction that we're going to push. I don't want you to miss out. So, it's not tilting his head back. It's not angular translation we're looking for. It's sagittal translation. With me? Mm-hmm. So forehead, tilt your head down for me a little bit. Oh, it's going forward, and then I'm pushing back at the same time, and clunk. Oh, well, it's better now, isn't it? And it's not what you want to hear. That is the Sharp-Purser test. And this is what it looks like in a real live human. Thank you very much, sir. This is what it looks like. What you're seeing there is the spinous process of axis. As this 12-pound bowling ball, due to gravity, has gone, because the restraint mechanism, one of the primary restraint mechanisms, don't get me wrong, there's apical, alar, muscles, ligaments, tendons. It's not just the transverse ligament in isolation, but that's the major restraint mechanism. So if that's insufficient, in his case, torn, that head has really very little holding it, so it goes forward, and then this sticks out. So the Sharp-Purser test, I'd have my hand on his forehead and my knuckle here, and I'd be pushing this way. And I would probably hear or feel that clunk. And that's how it's described in the literature. So there it is, right there. So this is how, in McGee's book, which is another board book, there's McGee, Cipriano, Souza, and Evans. Those are the 4 recommended references for orthopedics. Hoppenfeld is a bonus, and that's orthopedic neurology. But you can see that doesn't look comfortable, does it? And you got to really be good to get that little tip of that little thumb right on the tip of that spinous. It's easy to slide off it, and then you don't accomplish what you set out to do. Use the knuckle. Acceptable variant. So let's try. Do you understand how this works? Yeah. It's this way, not this way. It's not like you're trying to extend their neck. You want to create a shear. But remember, don't do it too hard, okay? Because it's uncomfortable even on a normal neck. You're not going to harm anybody.